1, 2,
and review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is also dropping.
45 minutes of CPR and no return of circulation. Okay.
Hey guys, this right here is going to be the pharmacology section or critical care pharmacology section. And this one is specifically going to be for your RSI drugs. Now, RSI is rapid sequence induction, or that's basically going to be your intubation pathway or your intubation algorithm, however you want to look at it. So you have a few popular and common sedatives, which are going to be etomidate, ketamine, propofol, and Versed, or midazolam, right, for generic name. And then your paralytics your two big ones are going to be rock and sucks. All right. So succinylcholine and rocuronium are competing for like top spots. But rock has a longer duration than sucks does. So if you got someone that's going to be a difficult intubation or a difficult tube, you're going to be probably using rock because you get that 30 to 60 minute window of paralytic properties. But you also have vecuronium. That right there was the med that Redonda Vaught accidentally gave her patient before she went for MRI or CT. And she gave way too much of it and robbed the lady's drive to breathe quite physically. So that's Vec. But the two most common drugs that I have seen used for intubation is definitely going to be etomidate and rock. Now, guys, because we all operate on a perverted mind, just always, always, always remember you're going to date someone before you suck them, or you're going to date someone before you rock their world. Okay? Easy way to remember it. So you're always going to put someone under. You're always going to sedate them before you paralyze them. Okay? So date before you suck, date before you rock. Right? So etomidate, rock, etomidate, sucks, or ketamine, rock, ketamine, sucks, whatever you guys want to use. Right? But that's kind of the way to do it. Okay? So all of the drugs that are going to be annotated with RSI are going to be your RSI drugs. Now, the exceptions are probably going to be midazolam and ketamine. Midazolam because it acts as also an anxiolytic, but it's not typically used for that, but it can be. And then ketamine is another chic drug that's coming back into popularity. After it was taken out of popularity, it's coming back with a vengeance. So just a quick thing on ketamine is low dose. You're going to be getting into that psychotherapeutic range where they use it for like CBT and stuff like that. And then you have the mid-range dose, which is going to be for pain control, like up to 50, I think it's 50 mics or maybe 50 megs. One of the two, it's 50 something. And then you have your mod sed, which is going to be anything over like 50 and above, right? From what I understand, and again, this is me, I'm going to learn it just like you guys. But from what I understand, ketamine does not really have the properties of slowing down respirations, but that's just what I've been told. And we'll find out together when we listen to the episode over ketamine. Okay. So again, this is going to be your RSI drugs. They're going to be annotated as such with RSI. And it's important that you know your RSI drugs because you as the nurse will be pushing etomidate. You as the nurse will be pushing rock. You as the nurse will be pushing Versed for these critically ill patients that you need to take their airway. Okay. So just kind of keep that in the back of your mind why you're giving these meds and listening to this, because you will be needing to know this as you're giving this med. Okay? All right, guys, enjoy the episodes.
Imagine the alarms in a critical care unit are just blaring.
Oh, yeah. Total chaos.
Right, total chaos. Your patient is fighting the mechanical ventilator, or, maybe their airway is swelling up and compromising rapidly.
And you need to secure a breathing tube right this second.
Exactly. Because any sudden movement, like a cough or a gag, it could completely tear the airway.
Yeah, you need absolute rock-solid stillness from this patient.
But the catch is, their blood pressure is already marginal. I mean, it's tanking. So how do you paralyze every skeletal muscle in their body without completely crashing their hemodynamics?
Well, you reach for a tool that offers profound, lightning-fast muscle relaxation, but keeps the cardiovascular system incredibly stable.
So you bypass those older drugs that, dump histamine into the bloodstream.
Right, exactly. Instead, you look to a specific non-depolarizing neuromuscular blocker.
Which brings us to today. Welcome to this deep dive. Today, we're taking a highly specialized approach to your source material. We're acting as your elite critical care pharmacist and nursing pharmacology instructor.
Yep, and we are aggressively applying the 80-20 Pareto principle to one major high-alert critical care medication, which is Rocuronium.
We're filtering out the background noise, right? Just giving you the exact pharmacological mechanics you actually need.
Because whether you're prepping to crush your NCLEX or an ATI exam, or you're the clinician literally standing at the bedside during a rapid sequence intubation, the goal is to make the why and the how of this drug completely second nature.
So jumping right into the expected pharmacological action, the mechanism, we should probably establish what Rocuronium is doing at like a molecular level first.
Yeah, so as you probably know, acetylcholine is the neurotransmitter that normally drives the motor end plate. It's what triggers a muscle contraction.
Right.
But Rocuronium has this specific monoquaternary aminosterate structure. Basically, it makes it a competitive antagonist at those exact cholinergic receptor sites.
So it's racing acetylcholine to the nicotinic receptors.
Exactly. It races there, binds to them, and just simply occupies the space.
I always picture it like a really high-stakes game of musical chairs.
Oh, that's a good way to look at it.
Yeah, like acetylcholine is walking around waiting for the music to stop so it can sit in the receptor chair and cause a muscle movement, but Rocuronium is just relentless.
Right. It gets to the chair first, sits down, and absolutely refuses to move.
So there's no depolarization at all?
None. The sodium channels never open, and the muscle literally cannot contract.
Wow. And that blockade, it results in a paralysis that progresses in a really specific way, right? Like a highly methodical anatomical sequence.
Yeah, it's never this chaotic all-at-once wave. Neuromuscular blockade always begins with the muscle groups associated with fine, rapid movements.
Like the eyes.
Exactly. It knocks out the muscles of the eyes, the face, and the neck first.
And then it just marches downward.
Yep. It moves to the limbs, then the chest and abdomen, and finally, it hits the most resilient respiratory muscle of all, which is the diaphragm.
And what's really useful for clinical monitoring is that when the drug is metabolized and starts to wear off, muscle tone returns in the exact reverse order.
That's a huge point. The diaphragm regains function first, and the fine motor skills, like the eyes and face, those are the very last to recover.
Knowing that predictable top-to-bottom cascade is incredibly useful. But I have to ask, if we're aggressively blocking these peripheral receptors and basically turning the body into a statue,
Right.
we have to talk about the central nervous system. Does this drug cross the blood-brain barrier at all? Like, does it provide any amnesia, analgesia, or sedation?
Emphatically, no. It absolutely does not.
Wow, okay.
Rocuronium only paralyzes skeletal muscle. It has zero effect on consciousness or pain perception.
That is terrifying.
It really is. The patient is rendered entirely immobile but remains fully aware of their surroundings and, sadly, any painful stimuli.
So you have ROC, solid muscle, but a wide-awake brain.
Exactly.
That single fact really dictates the most critical nursing interventions we'll cover in a bit. Because paralyzing a conscious patient without sedation, I mean, that is the literal definition of a clinical nightmare.
It's basically a torture scenario if you do it wrong.
Right. So moving on to how we apply this therapeutically, the on-label uses are pretty straightforward.
Yeah, it's used as an adjunct to general anesthesia. It's the drug of choice for many non-emergent and rapid sequence intubations, or RSIs, and it provides skeletal muscle relaxation during surgery or mechanical ventilation.
But the sources also detail this really fascinating off-label clinical scenario that goes way beyond just securing an airway.
Oh, the shivering protocol. Yeah, that's incredibly interesting.
Right. It involves managing overt shivering in patients undergoing therapeutic hypothermia after a cardiac arrest.
The physiology there is just a brilliant application of the drug. Because when clinicians cool a patient down to a hypothermic state to protect their brain after a cardiac
The body
arrest.
just fights it.
Right. The body's natural homeostatic response is to shiver violently to generate heat.
And shivering requires massive muscle contractions,
Exactly. Which burns oxygen and creates metabolic waste.
which completely defeats the entire purpose of cooling the brain down in the first place, right?
Yeah.
Because you're trying to lower its metabolic demand.
Precisely. And that's exactly why rocuronium is utilized there. When your standard sedatives and anti-shivering protocols fail, rocuronium can be given as, like, an intermittent IV dose or even a continuous infusion.
Just to paralyze those skeletal muscles and force the shivering to stop at the receptor level.
Yep, thereby protecting the brain's oxygen supply.
That makes total sense. Now, when we need to achieve this paralysis really fast, succinylcholine has historically been like the classic go-to paralytic.
Yeah, for decades.
So why choose this drug?
Yeah.
Why would a provider pivot and choose rocuronium instead? The source texts mention it was developed as an analog to vecuronium to rival the rapid onset of succinylcholine, but succinylcholine is a depolarizing agent.
And that depolarizing nature is the critical difference here. Succinylcholine basically forces all the muscle receptors to fire before paralyzing them.
Causing those visible muscle twitchings.
Right, fasciculations. But that mass firing causes potassium to leak out of the muscle cells and into the bloodstream.
Oh, wow.
Yeah, which can trigger lethal cardiac arrhythmias in patients who already have high potassium or, crush injuries or renal failure.
So rocuronium is a non-depolarizing alternative.
Exactly. It just blocks the receptor without firing it, completely avoiding that dangerous potassium shift.
And it still rivals the speed, which is crazy. The data shows that in adults, the maximum effect hits in, 1 to 3 minutes?
Yep. And in infants and neonates, the onset for ideal intubating conditions is a lightning fast 60 to 75 seconds.
That's incredible. But the real 80-20 distinction, the main reason you choose this drug for a hemodynamically unstable patient is its side effect profile, right?
Absolutely. Our sources really emphasize that rocuronium produces minimal histamine release and no ganglion blockade.
Right, because older paralytics are just notorious for causing mast cells to degranulate and, dump histamine into the patient's system as a side effect.
And a massive histamine dump is essentially an artificial allergic reaction.
Right, it causes systemic vasodilation.
Which completely tanks the blood pressure. And it causes bronchospasm, making the lungs incredibly difficult to ventilate.
So by avoiding that histamine release, rocuronium keeps the hemodynamics stable.
It does. Now, the clinical texts do mention you might see sinus tachycardia as a mild side effect.
Oh, really? Even without the histamine?
Yeah, since we know it's not driven by histamine, it's worth noting that rocuronium has a very mild vagolytic effect.
Meaning it blunts the vagus nerve.
Exactly. It slightly blunts the vagus nerve's normal braking action on the heart rate, so it allows the heart to speed up just a bit. But you completely avoid that severe, life-threatening hypotension.
Okay, that's a huge clinical pearl. So since this drug is keeping the blood pressure stable during a crisis, how are we actually getting it into the patient's system? The standard administration is an IV push, right?
Yes, given rapidly over 5 to 10 seconds, or it can be hooked up as a continuous IV infusion.
And there's a highly practical FDA update in the sources regarding its administration, mostly due to COVID-19 related drug shortages.
Yeah, this is a great practical tip. To prevent unnecessary waste of such a critical medication, the FDA now allows the 50 milligram and 100 milligram vials to be used beyond their previously labeled in-use time.
So once the vial is penetrated, it can be kept for up to 2 hours at room temperature.
Or up to 4 hours if it's refrigerated.
That's good to know.
Yeah.
Now, the physical properties of the liquid itself require massive clinical caution, right? Because rocuronium is formulated with an acidic pH.
Highly acidic, yes.
I'm just imagining a chaotic resuscitation where a clinician pushes rocuronium through an IV line that just had an alkaline drug running through it, like thiopental or sodium bicarbonate.
Oh, that is a severe IV incompatibility. You do not want to do that.
What happens?
If an acidic drug meets an alkaline solution inside the IV tubing, it causes a physical precipitation. The drugs instantly crystallize, forming a literal white snowstorm in the line.
Oh, wow. A snowstorm in the IV line.
Yeah. You cannot mix them in the same syringe or push them through the same unflushed line because those crystals can cause a devastating embolism.
That's terrifying. Furthermore, if extravasation occurs, meaning, the ID catheter has slipped out of the vein and this acidic drug starts leaking into the surrounding tissue.
You have to stop the injection immediately.
Right, and restart in an entirely different vein to prevent tissue necrosis.
Exactly. Which brings us to the absolute priority nursing interventions. These are the never events of administering neuromuscular blockers.
The foundational rule, written in stone, is that adequacy of respiration must be assured. You are actively paralyzing the patient's diaphragm.
Right. Assisted or controlled mechanical ventilation is mandatory, non-negotiable.
And tying back to our earlier discussion about the brain, because rocuronium does not alter consciousness, the clinician must administer it only after unconsciousness has been induced.
Yes. Adequate amnesia, sedation, and analgesia are an absolute prerequisite.
The source texts actually feature a critical storage alert that speaks to the sheer danger of this medication. Accidental administration of a paralytic to an unsedated, non-ventilated patient is fatal.
It happens tragically. To mitigate this, rocuronium must be stored with the physical cap and ferrule entirely intact.
Because in a high-stress environment, cognitive load is maxed out. You don't want someone reaching blindly for a saline flush or a mild sedative and accidentally pulling a paralytic.
Exactly. Keeping that physical cap intact creates a forced barrier. It demands that the clinician pause, look at the label, and explicitly confirm they are holding rocuronium before they pop the top.
That forced pause saves lives. So, okay, once the drug is pushed and the airway is secured, the clinical focus naturally shifts to evaluating the depth of that paralysis.
Usually using a peripheral nerve stimulator.
Right. You deliver a small, localized electrical current to a nerve, typically the ulnar nerve, the wrist, or the facial nerve, and you watch for the corresponding muscle to twitch.
And the clinical target for a continuous infusion is typically 1 to 2 twitches out of a rapid sequence of 4 shocks, which is known as a train of 4.
I noticed a major caveat in the literature regarding those nerve stimulators, though.
Yeah.
The results can be skewed by incorrect electrode placement or using electrodes that are too large, but it also warns about patients with severe edema, acute illness, or capillary leak.
That's a really common issue in the ICU. Water acts as an incredible resistor to electrical current in human tissue.
Oh, really?
Yeah, if a patient is critically ill and third-spacing fluid, meaning their arms and face are severely swollen with edema, the electrical current from the surface pads might not even penetrate deep enough to reach the ulnar nerve.
So the monitor might show 0 twitches, leading the nurse to think the patient is deeply paralyzed.
When in reality, the electrical current just isn't making it through the fluid, the patient might be waking up.
Wow, that's exactly why you can never rely solely on a machine. You must continuously monitor visual and tactile muscle movement.
Watch for unexplained spikes in heart rate or blood pressure that suggest the patient is waking up, and ensure they are synchronous with the mechanical ventilator.
Okay, let's examine the complications. Beyond the expected but deadly risk of profound apnea if you lose the airway, the sources highlight severe bronchospasm, anaphylactoid reactions, and malignant hyperthermia.
Right, which is that rare, life-threatening genetic reaction to anesthesia.
But there's also a delayed complication called acute quadriplegic myopathy syndrome, or AQMS.
Yeah, AQMS is a devastating condition. It's where a patient experiences profound, generalized muscle weakness that lingers for days or weeks after the rocuronium infusion has been completely turned off.
So it's not just the drug wearing off slowly.
No, it's an actual myopathy. It's a pathology of the muscle fibers themselves, often seen when paralytics are combined with high-dose corticosteroids in the ICU.
That is a terrifying prospect. I mean, surviving the acute respiratory failure but being unable to move your limbs or wean off the ventilator for weeks?
It's a massive setback for recovery.
Tracing how the body clears this drug helps explain some of these other risks, I think, because it's metabolized in the liver, specifically by the CYP3A4 enzyme system.
Yep.
And it distributes heavily into the extracellular space rather than into fat tissue.
And this pharmacokinetic profile requires major adjustments for patients with hepatic impairment.
Because the liver is compromised.
Right. While a diseased liver might not drastically change how fast the drug initially works, it severely prolongs the recovery time because the liver simply cannot clear the molecules out of the bloodstream efficiently.
Wait, hang on. I need to logic this out.
Oh.
Because the sources note that for patients with ascites, which is, a massive accumulation of fluid in the abdomen, usually due to profound liver failure, we actually need to give a higher initial dose of rocuronium.
That's right.
But if the drug is cleared by the liver, and ascites indicates the liver is failing. Why on earth are we giving a higher initial dose? Shouldn't a sick liver dictate a smaller dose to avoid toxicity?
I know, it feels incredibly counterintuitive until you separate the concept of volume of distribution from clearance.
Okay, break that down for me.
Because rocuronium is water-soluble and distributes into extracellular fluid, a patient with massive ascites has a much larger fluid bucket inside their body.
Ah, so if you give a standard dose, the drug just gets too diluted in all that abdominal fluid before it can reach the muscle receptors.
Yes, exactly. You have to give a larger loading dose just to fill that massive volume of distribution and achieve an adequate concentration at the neuromuscular junction. Right. Then the failing liver's terrible clearance rate comes into play. That higher initial dose is going to result in a massively prolonged duration of paralysis because the liver cannot sweep the drug away.
That is a brilliant clinical nuance. Higher initial dose to overcome the fluid volume, but expect a much longer recovery because the liver is compromised.
Yep. And similarly, patients with renal failure may experience a highly variable duration of effect, making their recovery time far less predictable as well.
Let's look at special populations real quick.
Yeah.
The pediatric data in the source material presents a really interesting dilemma. It details the bioavailability of giving rocuronium via an intramuscular or IM injection at around 82.6%.
Right.
Yet, in the very same section, it explicitly states IM administration is not FDA approved and is absolutely not recommended. Why even study it and publish the bioavailability data if clinicians are explicitly told not to use that route?
It really stems from the sheer desperation of pediatric emergencies. In a crashing infant or child, their peripheral veins clamp down, making establishing an IV line incredibly difficult, sometimes entirely impossible.
So clinicians have just desperately searched for a fast-acting paralytic that can simply be injected into a muscle for those nightmare scenarios where you have no IV access but desperately need to secure an airway.
Exactly. So researchers studied injecting rocuronium directly into the deltoid muscle of children to see if it could act as a rescue pathway.
But the pharmacokinetics of a crashing patient worked against them, didn't they?
They did. When a child is hypoxic and their blood pressure is dropping, blood flow is shunted away from the skeletal muscles to protect the core organs.
And an IM injection relies on good muscle perfusion to absorb the drug into the bloodstream.
Precisely. Because the muscle wasn't well perfused, the drug basically just sat there in the deltoid.
Wow.
The clinical trials showed that adequate intubating conditions were not consistently achieved fast enough. I mean, waiting 7 to 13 minutes for an IM paralytic to work is a lifetime when a child's oxygen saturation is plummeting.
So because it failed to provide the rapid, reliable onset required for a life-or-death airway situation, the IM route remains strictly not recommended.
That's the bottom line.
Turning to pregnancy and lactation really quick, the safety profile for breastfeeding mothers is actually quite reassuring in the texts.
It is. The sources give a green light to safely resume breastfeeding 90 minutes to 5 hours post-anesthesia, with no adverse effects observed in the infants.
And that's because the molecular characteristics of rocuronium make it highly unlikely to pose a threat through breast milk.
Yeah, it has poor lipid solubility, meaning it struggles to cross cell membranes to get into the milk ducts in the first place. It also has a relatively short half-life of 1.4 to 2.4 hours in healthy adults.
And even if a tiny fraction of the drug did somehow make it into the breast milk and the infant swallowed it, rocuronium has notoriously poor oral absorption. It would simply pass through the infant's GI tract without crossing into their bloodstream.
Exactly. It's very safe in that regard.
Okay, so to wrap up our mission today, let's distill all of this pharmacology into our final 80-20 clinical review.
Let's do it.
The memory hook to cement this in your mind is ROC solid. Rocuronium leaves the patient's skeletal muscles ROC solid and paralyzed from top to bottom, but leaves the brain entirely untouched.
And the reasoning pattern you want to internalize starts with the mechanism. It is a non-depolarizing agent that competitively blocks acetylcholine at the nicotinic receptors,
which causes that physiological effect of top-to-bottom skeletal muscle paralysis.
Which then dictates the therapeutic use, creating the ultimate stillness for rapid sequence intubation and mechanical ventilation.
And the adverse effect to fear most is fatal apnea if the patient is conscious and the airway is lost.
Which brings us to the absolute priority nursing interventions. You must sedate the patient first, and you must have a mechanical airway ready and assured before you ever push the drug.
So if we're talking about the 20% you absolutely need to know, the highest yield facts are clear. Rocuronium rivals the rapid onset of succinylcholine acting in just 60 seconds for infants. but completely avoids the depolarizing muscle fasciculations and the dangerous potassium shifts.
It also avoids the massive histamine release seen in older paralytics, ensuring your patient's hemodynamics remain stable without severe hypotension or bronchospasm.
We also absolutely must remember the physical incompatibility. Never mix this acidic drug with alkaline solutions like thiopental, or you're going to create a crystallized precipitate in the IV line.
And remember that liver failure or massive ascites will radically alter both the required initial dosing and the patient's recovery time.
Right. And crucially, the provided source text does not list a specific antidote or reversal agent for rocuronium.
That's a huge point. If you push this medication and cannot secure the breathing tube, your primary clinical fallbacks are simply the passage of time and forced mechanical bag valve ventilation until the drug naturally metabolizes.
Which is a terrifying situation to be in.
Yeah.
You know, we spent a significant portion of this deep dive discussing how clinicians evaluate this profound paralysis using a peripheral nerve stimulator, literally shocking a nerve, and visually counting how many times the thumb twitches.
Yeah.
When you step back, it feels almost, I don't know, archaic.
It really does.
As medical technology accelerates, you just have to wonder how much longer critical care will rely on a clinician's subjective eyesight to measure something as high stakes as a neuromuscular blockade.
It's a fascinating space to watch, honestly, because we're already seeing the emergence of continuous, non-invasive electromyography patches. Yeah, they can quantify the exact percentage of receptor blockade in real time. They objectively read the muscle's electrical activity rather than forcing a nurse to feel for a twitch through, like, heavily swollen tissue.
A technology that could just entirely remove the human error of misinterpreting the depth of paralysis. That would be amazing.
It would change the game.
But until those closed-loop, AI-driven monitoring systems are on every single ICU bed, you and your clinical vigilance remain the ultimate monitor. Thanks for taking the deep dive with us.